Good afternoon. Good afternoon, everyone. Oh, it's a lively crowd. Hi, good afternoon. We're going to start our afternoon session. Actually, two sessions. Hi, so our third session today is called Extending the Reach of Patient Navigation Programs to Address Health Disparities, Innovations and Next Steps. As you heard this morning, there's a lot of different models of care, and I think we heard a lot of conversations at lunchtime today about different ways we can address particular populations, how we can address disparities and promote equity, and how we can reach diverse populations. And this session is specifically designed to start talking about those particular facets of navigation programs. I'm going to welcome up to the podium Melissa Simon. Melissa is an obstetrician and gynecologist at Northwestern, and her work has been involved in cultural adaptation of navigation programs, particularly with women and families. And her title of her talk is Patient Navigation to Promote Health Equity, the Case of Chicago.
Good afternoon, everyone. Come on, I need more energy. I'm the first talk after lunch. Come on, let's go. Good afternoon. Thank you, thank you, thank you, thank you. All right. Okay, let's go. I have nothing to disclose, but because I'm a member of the United States Preventive Services Task Force, I always have to say I'm a member, and what the content of my talk doesn't necessarily reflect the views of the USPSTF. I'm also, for disclosure, a member of the roundtable here at NAM for promotion of health equity, and a member of the Innovation Collaborative here at NAM for patient shared decision making and care culture and decision making. So the handoff. So a lot of, there's going to be repetitive themes now starting to come up as we move forward in this workshop over the next day and a half. And you're going to hear some of those repetitive themes in my talk. So the handoff's really important. We practice this in many different ways, right? Some of those that you can align with here, giving you the keys for the first time to your 16-year-old to go drive. I'm not looking forward to that. And as an obstetrician, I get to hand off babies to families, right? And if you think about patient navigation, we really have to think about all the complexities of the healthcare system at all the levels, from everybody's viewpoint, right? The healthcare system, the clinics, the hospitals, the providers, all the different types of providers, the team, and the patients, right? And nested within communities, right? And then you got to figure out that handoff and all the gaps and actually the good things that happen, the good and the bad of the handoff, and where we can make it better and improve connectivity. Also, architecture. So I have 4 children, 13 and under, and this is a lot of what happens in my house, right? We got Legos, we've got Greek history, and right, Roman history, and Minecraft, and all that cool 3D printing. But architecture and design is actually super important. And whether it's about workforce development, getting people through pipelines, who do we accept into medical school, nursing school, PhD programs, et cetera, and how do we nurture the K through 12 STEM people from diverse populations to really meet the workforce and healthcare needs. But how about all the architecture of policies and practices and quality of care that happens at every level throughout the system? The other thing we have to think about is implementation. So I heard a lot about implementation. I'm the study section chair for NIH's standing DIRH, which is the Implementation Research and Health Study section, and I get a lot of this. So what's the minimum level of evidence needed to implement? How many studies do you need, right? And then on the USPSTF, there's that highest bar standard in order to create recommendations, grades for certain preventive practices for the country, right? So what's the minimum level of evidence? What works? So there's a real science to implementation science, and it is meant to really close the science practice gap, right? So this is just one of many frameworks that we use in implementation science, but what the overwhelming issue or things that you want to consider, right, is the outer setting, the individuals involved in the inner setting, right, and it's iterative, just like architecture and design. So those of you who took art in school at one point during your life, Design 101 is iterative. Right, it's an iterative process, and that's exactly what happens here. And those of you who have an MBA in management school, you learned in systems engineering, it's an iterative process, hence rapid cycle process improvement, right? All right, I also want to make sure, because I learned a long time ago that sometimes I speak a little too fast and I don't bring people along. And just a little quick primer on inequity so we're all on the same page with definitions. So inequity is a systems of structuring opportunity and assigning value based on whatever, fill in the blank, which unfairly disadvantages some individuals and communities, and unfairly advantages other individuals and communities. And there's many axes of inequity. So health disparities, like I hear a lot, right, don't just focus on race and ethnicity. They're not synonymous, right? There's a whole host of axes of inequity. The other thing I want to point out is the difference between equality and equity. So if you think about it, we're all in an apple orchard, okay? And the goal for the people that you've brought with you to the apple orchards is to pick an apple. And you want everyone to come out of that orchard with a delicious tasting apple, right? Now, equality would be I give every single person the same box to step on to reach an apple. Same height, same weight, same size. But yet, we acknowledge on the left side of the screen, if it's equality that we're talking about, the box, if it's the same size, may not suffice for some of the shorter people who are in my group to get the apple, and they're not going to make the outcome that I want. They're not going to come out of the orchard with the apple. All right, they may get one on the ground that has a worm in it or something. All right, that's not good. All right, equity. Equity implies that we have a different size box. We acknowledge that we have to have a different size box for different height people so that everybody can get that apple. And they can pick the apple that they want off the branch and leave the apple orchard as a group together with the apple in their hand. It's the same thing that Dr. Freeman talked about earlier with the flight. Everyone getting on the airplane together, everyone getting their needs attended. So if you think about patient navigation and improving quality of care and equity, it's adjusting that box. Are you all with me? Yes. All right. Okay. The other way I look at it when I teach people about this is there's two cliffs. Why are there two cliffs? Why do the folks that are orange and red up at the top on the far cliff have primary care, which is the red little strips, pink, red strips up there, and then have some secondary care, which is that purple lavender line, and then have an ambulance that actually functions with a good GPS and tires that aren't flat and has a full tank of gas? Whereas the people on the other cliff that are green, why don't they have any of that? Or if they have it, why is it's scattered or spotted or has holes in it, or why is the tire flat in the ambulance or the GPS broken, right? Why? What's the difference between those two cliffs? And that's what we really are trying to seek in health equity. So they're huge issues to tackle. All right, Chicago. So I'm going to use the example of Chicago patient navigation. We've been on the ground, and I have lots of colleagues and friends in the room. Dr. Paskett and Dr. Battaglia and Mandy Chapman-Pratt were all with me in the original U01 Patient Navigator Research Program, and thanks to Dr. Freeman for really helping spearhead this and move things forward. And thanks because you've also supported my career, and I really appreciate that one too. Breast cancer disparities in Chicago. So like I said, you got to know about the hurdles, right? You got to know about the architecture and design. What are the policies and practices in Chicago? And then how you implement stuff. And the fundamental understanding of inequities. So in Chicago, if you look back in the 1980s on the left side of that graph, the breast cancer mortality rates for black and white women were about the same. And the black women's line is the magenta, dark pink, red line. But if you look as we advance in time to the right, to around 1995-ish, you start to see the mortality gap widen. And that nothing that we did in Chicago, this is Chicago with 5 major academic medical centers, including my own, I'm gonna call out Northwestern, 2 comprehensive NCI, comprehensive cancer centers, right? What happened that made the mortality for Black women to breast cancer pretty much stagnant between 1981 and 2007? What happened? And so some of us in Chicago will say, oh, New York can't be any better, right? And we looked at the data, and actually, they were much better. So this is the Black-white mortality disparity. It was 27% in breast cancer for New York City. United States was about 41%, and Chicago was 62%. What is going on, right? You got to know about the on-the-ground stuff. So where does that problem preside? Inside the woman or outside of the woman? Is there biology, genetics, psychology? Access to mammography, quality of mammography, quality of treatment. And the possible solutions really, do you fix the woman or do you fix the system? Right? So we know that we couldn't just fix one thing, that we had to fix the system in multiple ways, right? And we launched a very large campaign and created a Metropolitan Chicago Breast Cancer Task Force and really just made a whole movement around improving this breast cancer disparity. And so just looking at the ecology of breast cancer disparities, which are each of the circles, starting the inner circle, the interpersonal barriers and the community barriers nested within health system barriers, nested within public policies. And so things that you can do try strategies that you can do to try to rectify some of these situations. Navigation really hits at that inner core circle, interpersonal barriers, and that aligned with health system barriers and quality improvement. And that's what we found really worked together, along with a whole lot of advocacy and bills that became laws from our data. So I like to collect qualitative data and stories of patients and people from the community, because they can tell the story the best, better than I can as a healthcare provider to minority women. The quality of care you get from a public health clinic is not going to be the same quality of care you get from a private physician. You can walk in the Board of Health, and it's a completely different atmosphere than the Northwestern Lynn Sage Breast Cancer Center, where you've got nice lights, TV going, soft jazz playing, and you got coffee, snacks, and can I help you attitude as soon as you walk in that door. They are going to take care of you. And if you go to the Board of Health Center, there are 30 people all at the same time, and you got to sit there and wait. And that's the reality. And it's not to say that the Stroger County Hospital that we work with, our residents train through both hospitals. Yes, I work next to Neiman Marcus in the Gold Coast, but it's not to say that the Stroger Cook County Hospital care is any worse. It's just that the reality of the care is that it's clogged up. The system there's a high need, right? You also have to understand what actually happens on the ground in clinics. So what we did is we did a very massive citywide assessment of imaging sites, federally qualified health centers, community clinics, and we actually followed people around. We did something called an environmental scan. And so you follow a patient from the time she hits the door of the clinic or the imaging center until she leaves, and you document every single process of care. All of it. And so we did that, and it's obviously very complex. I mean, even you and I, right? When we go to clinic and we get a diagnosis and we have to go get a test, and then we have to get a second test, and then we have to go to another place and get yet another test, or then we have to get surgery. And it's very complicated for us. So it becomes even more complicated for people who are publicly insured or uninsured and have less resources, because usually they're getting care at many different sites as opposed to it all in just one center, okay? And then this is just another way to view that, the patient seeing the primary care physician, the radiologist, the breast surgeon, the plastic surgeon, genetic counselor, medical oncologist, and case management, blah, 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 blah. And oh, by the way, there's all these health insurance issues that you have to work out, or other things if you're not insured. So it's super complicated, right? So the other thing we had to get our act together on was to look at what was going on around the county area and the city and the county. So this is this is not just Chicago. I wish I had I don't have a pointer, but what you see is the darker reds have higher rates of breast cancer. These are like heat maps, and you'll see the far right in the middle is like around Chicago, Cook County, and then just to the left of the word Cook on that map is DuPage, and it's really dark red. Well, what was happening is a phenomena that's happening around the country that not all poverty goes into the city center, right? There's the poverty, people migrate out of the city. People also touch base first in the suburbs because they want better schools, right? Better homes, just like you and I, right? Less violence, right? So what happens in the suburbs is, oh, thank you, I'm being tutored. Thank you. It's the other green button. I heard about the green button this morning. I was like, I can do it. I didn't realize there's 2 green buttons. But the public health safety net is totally underdeveloped in many suburbs. Some suburbs have it better than others. But so what was happening in DuPage County is that there are a lot of Latinas, first generation coming in from Mexico, landing in and settling in DuPage County. But DuPage County didn't have the public transportation aligned with the Health and Human Services. That's what we did. We did a project on that. They didn't have a county hospital. They didn't have a whole bunch of things that you would expect that you would get in a city. So we created the DuPage Patient Navigation Collaborative, and it was right near the tail end of the Patient Navigation Research Program. So this was kind of like an implementation project, but it was at the community level. So we had community health workers or patient navigators or promotoras that were at a freestanding community organization called Access DuPage. They were not alleged to a particular health system or hospital or clinic, so they could move freely with the women in the community and guiding them and navigating them around. And it was really important. They also leveraged every single community health service, human health and human service across the entire county of DuPage. And what we had been seeing, because this was a community engaged research project, the organizations that were on board with us were saying, well, we know there's poor women here, and we know there's women who need services, but we can't find them. I'm like, don't worry. We will get everybody together, and we will find them. And sure enough, we did. And so what you see is, from the results, is so compared to English-speaking patients, Spanish-speaking patients, and this was a pragmatic trial, had lower income, lower health literacy, lower patient activation, and were more distrustful of the health system. And basically, just like you saw with Dr. Pascat's data this morning, there were the patient navigators mitigated the disparity. There were no differences in likelihood of delayed as defined as greater than 60 days of follow-up by language. And patients entering the study with higher health care system distrust had lower likelihood of delay follow-up after abnormal cervical cancer screening and breast cancer screening. The other thing that we found out from this project is that the patient navigation just didn't help individual patients, it helped the community organizations and the health and human services organizations connect to each other at a county level. Now, this is the second largest county in Illinois. The first largest county is Cook County, Chicago's Cook County. So 1 million people in DuPage County. And so we found increased bonds between all the health and human services, the Department of Public Health in DuPage, American Cancer Society of DuPage, all the hospitals in DuPage as well. So there was more connectivity as we moved through the program. The other things that we've done is look at other communities and how do we just put patient navigation in, the Chinese community, for example, and let it go? Well, you can, but then you've got to study all the nuances and adapt it for that particular population, okay? So we work a lot with the local Chinatown community in Chicago, and we are on the ground. We've enrolled 722 patients, women, for breast and cervical cancer screening in Chicago in the Chinese community. And this has been really important because what spawned this one wasn't only the curiosity of how you implement with Chinese community, but this is my decades-long relationship with Chinatown community organizations saying that docs that work there aren't recommending mammograms because they don't think Chinese women get cancer, or they don't think that Chinese women will go to get their mammogram if they're referred. You know, I've spent a lot of time in China, and breast ultrasound is the standard, and also preventive care services are framed very differently than they are in the West, in the Western world. So it was a real bridging activity that we had to do, multiple community talks and all kinds of canvassing to really get this tailored correctly for this community and to get good outcomes. We also, this is another exemplar of implementation where we're partnered with Sinai Urban Health Institute and Mount Sinai Hospital in Chicago, which is on the west side and south of the city, or predominantly Latino and African American neighborhoods. And the thing about that one, this project, is that we were looking at benchmarks. So you're going to get a little bit more into metrics later on tomorrow and today. But really trying to lay out, if you're planning for a patient navigator or a community health worker, what are the metrics should you expect to achieve over a period of time? So we have a paper that really looks at, community outreach activities. How do you do this at that canvassing community level? So I'm really talking about lay patient navigators. That's really, I'm aligned with Dr. Pasquet on that one. And how many women do you expect to meet in the community? So we actually take metrics for each of the community outreach activities, whether it's like a health and resources fair, food pantries, schools, churches. We actually get pink sheets. We keep counts of what people and how many women we touch within a certain community outreach activity within a certain community, because it's different for different communities, right? Whether you do a food pantry in one community, it might not be a good strategy for another community. And then we really are looking at delineating then with the number of women that we touch, how many do we actually navigate for mammograms? How many do we actually get completed mammograms? And then how many do we get to send reminder cards? How many can we actually retain over time? And that is an important one. And finally, improving breast cancer quality of care, because as Dr. Battaglia appropriately said, you can't just put a patient navigator into a broken health system and expect it to work. Patient navigators are not Band-Aids, right? They're part of the solution, but we have to understand that the navigators are actually giving us super important information. They're teaching us all the gaps and bumps that the patient is bumping through that we didn't have the glasses to see, right? We didn't have the lens. Our lens was clouded or shaded for some reason or foggy. And we missed along the way that these patients are bumping along, and these navigators are giving us data as to where those bumps are, right? Which doc is not following the guidelines, right? Which clinic is not actually connected well enough to the lab to get the results in an efficient way, right? Which imaging center is not calling their patients with their results, right? All those things. So that's what we're doing now, thanks to the Merck Foundation and the Cancer Care Alliance. I know Dr. Leslie Hardy is here in the audience as well, and I want to thank her because part of her funding has helped us to start really getting these care plans and sequences of care. Again, I work with systems engineers to help facilitate navigation and lay out the sequences of care for each of the care team members between primary care clinics and tertiary cancer centers. And that's what we're doing now on the ground. We just started it. So it takes a village. You've heard that before. Modifying architecture, it takes a whole lot of education and awareness, because some communities aren't even with us. Remember I said, are y'all along with me? Some communities need more awareness. And we're so far ahead thinking, oh no, we don't need any more education and awareness. That's silly stuff. We actually have to keep this up. This is super important, especially when the healthcare landscape is as uncertain as it is today. We have to maintain education and awareness across all communities. Advocacy is super important, obviously, and navigation is important, research and quality improvement. So I get to tell you the happy story of the trend is that the mortality is decreasing. The gap between Black and white women in Chicago is decreasing, and it continues to decrease. So this is not all due to patient navigation, but a lot of it is. And I'm really proud to say that at least we're working towards this. This is still not good enough, though. So health inequities just don't happen. Architecture and design, don't forget, it's iterative, right? It applies to many things that we do, and we have to sometimes step back and really think about what it is. How did this get here? What kind of policy is this, right? And patient navigation does promote cancer health equity and really bridging the research to practice. So I hope I showed you some examples of really the bridge between getting the research from the community all the way back to the hospital, right, and that bench, and really going back and forth, and it's really important to get it right. And resources are required and challenging, and it does take a village. It is the we and not the me, and we have to think outside of the box. Thank you very much.